Hi, everybody. Master Clinicians proud to present our first COVID-19 panel discussion. Today, Saturday, April 18th, 3 p.m. We have a great group of physicians here working at the front lines in New York City. My name is Dr. David Shi. I will be the host and moderator today. Please allow me to introduce our three medical directors that are working in emergency medicine and urgent cares. The first doctor is Dr. Melissa Liebert. She is board certified emergency medicine physician and certainly working in one of the New York City hospitals. A second guest is Dr. Frank Galuzzi, also a board certified emergency physician. He's currently the EVP of Quality and Medical Education and was a former CMO of CityMD Urgent Care. And our last guest is Dr. Rupo Bengradia. She's the Chief Medical Officer for MedExcel, which includes New York Doctors Urgent Care. And she's currently a board member of the New York State Academy of Family Physicians. All right, welcome. So, these three doctors are spending a little time with us today, and they'll share some of their insights with us, some advice, discuss some of their experiences facing patients with coronavirus. This is recorded on our Master Clinicians YouTube channel. And, if you're not able to see this live, you can take a look at it later. If you want to learn more about Master Clinicians, you can join our mailing list at masterclinicians.net. Okay, guys, let's start. Let's start off with some few basic questions. And, the main thing I wanted to bring you guys together is to hear about your experiences and what it's like being on the front lines. So maybe we start with Melissa, and maybe you could tell us what you're seeing and, working in the hospital, in the emergency department. Have you ever seen something like this before?
I've definitely never seen anything like this before. I don't really think anyone has in our current times, and I hope we never see anything like it again. But we're seeing everything from patients walking in who are, we call worried well, who just want to be tested and they're worried and asymptomatic, or if they've been exposed. And then we see patients who suddenly became very sick, and those who gradually became very sick. And we're seeing patients coming in incredibly sick, more than you would ever imagine, from their respiratory illness.
Yeah, and how about our colleagues from the urgent care side? Frank?
Sure, Dave. Thank you. To echo Melissa's point, I don't think anybody in medicine has seen anything quite like this. In various different epidemics that we've seen, there may have been elements of this in terms of infectability or in terms of severity, but and fear. Whether you're talking about the Ebola outbreak and everybody was afraid about that, or SARS or MERS, it had the infectability aspect of it, and even those of us who were practicing during the AIDS epidemic, the fear that healthcare workers felt, when they were treating a disease that not everybody knew everything about, and they were concerned about how they can deliver care to their patients. But getting all of that wrapped up into one, this is something that we haven't seen. We're also, we're seeing a lot of volume. We saw some of the initial outbreaks, when it broke out in New Rochelle. We have a couple of sites in the Westchester area, and we saw that little mini outbreak. Then we saw, we have a number of sites in Manhattan when it exploded in Manhattan, and we were taking care of that. And now it seems like the hot zones are in Central Queens, South Brooklyn, and the South Bronx. Where we're working, and we're seeing tons of patients coming in. And again, to echo what Melissa says, it's amazing how the variety of presentations you see from people with sniffles and the worried well to people who are just profoundly hypoxic and profoundly sick, and everything in between. This is a difficult one in terms of identifying people and figuring out why some people get very, very sick and some people don't.
Thanks, Frank. And Rupo, what are you seeing, from your front?
So on the outpatient setting in an urgent care center, we are seeing this disease presenting in all forms, from patients who have been exposed and are just asymptomatic, having mild symptoms, And then there are patients who, go very quickly from being mildly sick to, needing to be hospitalized and eventually being put on a ventilator. The fear that patients are experiencing is very real, and I've never seen anything like this before.
Now, with the New York State being shut down with the New York Pause mandate, are any of your sites closed?
So we had one of our two Manhattan sites were closed for the last week or so, but we will be reopening on Monday. So we are going to be testing patients again in our centers.
Okay. How about you, Frank? Are you seeing? You're saying you're seeing volume, but are all your sites open, or some of them closed?
So we've strategically closed certain sites. Part of it is when you have, staff that may have been exposed or taken care of people initially before everything exploded. We had taken care of patients who ultimately rolled in for COVID, and we had to quarantine certain providers and certain, staff members at certain sites. So there were certain sites that we had to close and quarantine people for 14 days or 21 days. Since that time, when you're taking care of these patients, you have to expect that certain members of your staff are going to become ill or have to become quarantined. So we've closed a couple of our sites and strategically reallocated. So we're still serving in all the communities that we're in, but one of the maybe the lesser volume sites in a particular area, we may close that down so we can then reallocate that staff to the two neighboring sites to help bolster the staffing there so we can meet the needs of the community there.
So what are some of the common symptoms that you're seeing, and maybe some of the uncommon symptoms you're seeing, Melissa?
So common symptoms are fever, though not everyone has to have fever to have COVID. Upper respiratory symptoms like coughs and colds, of course, a cough. Patients may have shortness of breath or may not complain of it at all. In terms of like the signs, it's hard to believe, but patients even with some bilateral pneumonia from this don't even have the hypoxia that you would expect until late, and they can maintain their O2 stats until they get very sick. But we were talking even before this that we even see some right lower quadrant abdominal pain or random abdominal pain, and they'll be febrile and tender in their abdomens, and we'll get a CAT scan which shows the upper lung fields right above the diaphragms, and you'll be able to see they have the bilateral pneumonia classic for COVID, but it's just presenting as abdominal pain. Maybe others have other atypical symptoms to share. But.
Yeah.
Rupa, are you seeing any high risk factors or demographics that's affecting COVID more often?
Yeah, so we are seeing that the African American communities are disproportionately impacted by COVID. Many are essential workers, working in transit or the MTA. They do have higher rates to begin with of hypertension, asthma, and diabetes.
And Frank, I think we had a discussion offline. You have been noticing the chest X-ray findings for a lot of these patients. You want to share some insight on that?
Sure. So like RuPaul had mentioned, being out in the outpatient setting, we're seeing the COVID cases actually a little bit earlier. I mean, when the symptoms are mild or people are just starting to get what they think is allergic rhinitis or they think of a bronchitis or something like that, they are seeking us earlier, maybe the first day or two that they have the symptoms. We actually just published a paper that's going to be coming out in the Journal of Urgent Care Medicine, where we took a look at the first 3,000 patients that we had diagnosed with COVID, and I think it were about 700 of those patients obtained chest X-rays, and we looked at the findings of early chest X-rays in the outpatient population, and we find that there's a chest X-ray lag. We have patients coming in who have awful breath sounds. They have bronchi or rales, and bilaterally or unilaterally, and you'll take the initial X-ray, and over 65% of them were negative. Or they might have a single multifocal, a single unifocal area of just a mild interstitial pneumonia. And then they come back 3 or 4 days later, and now you see another focus of pneumonia in the other lung in a different spot. And then if they come back 5 or 6 days later, that's when you start to see kind of the diffuse patchy infiltrates. So it does look like there's a lag in terms of the chest X-ray for patients coming, with this disease. So you can't use the chest X-ray as a stratifier in terms of who's going to be serious and who's not. As Melissa mentioned earlier, there are a number of patients we saw with bilateral diffuse setting. At the same time, people who had normal chest X-rays who were setting in the mid-80s, and you knew that they were sick. So you can't really go by.
Thanks, Frank. Melissa, are the emergency rooms doing a lot of CAT scans on these patients, or are they just clinical?
No, we're getting CAT scans on very few patients, mostly chest X-rays, if that, because in reality, patients kind of want to be in and out if they can, and the chest X-ray is not going to change our management at all. If they have the bilateral pneumonias, and if they have, and if their O2 sat is okay, then we're actually still sending them home. So having a bilateral pneumonia doesn't mean that they get admitted. And so if patients just want to be quickly seen and discharged, then we're just skipping the X-ray altogether. Yeah. Well, because we're still low on tests in our area, or at least in our hospital, we're not testing all comers. So we are testing patients who either had high-risk exposure and have symptoms, or testing patients who really the main reason for testing is if they have to be admitted to the hospital. If we can discharge them, we're not testing them, and we're sending them out, telling them that they have COVID and that they should isolate at home, assuming they have it. But otherwise, we're trying to save the test for patients who are getting admitted so we can cohort them correctly.
To the urgent cares to get tested. What are you guys doing for testing, and how are you screening these patients?
So, we're working with a few commercial labs, so we have a little bit more access to test kits at the moment. We are still trying to limit the test to patients who are symptomatic, whether with, the more common or atypical symptoms, or patients who are high risk that have been exposed. Family members of patients who are positive, essential healthcare workers, or just essential workers in general.
Are you guys using any of the point of care testing, like the Abbott machines, that 5-minute machine, or any of the point of care tests?
It would be great if we had access to it at the moment, because it would give us, more rapid results, but we don't have access at the moment. So we're still using just the commercial labs with the nasopharyngeal swabs. We're getting results back in about 2 to 3 days on average. And then, if the labs get a little overwhelmed, we are seeing delays in results as well.
Okay, thanks. Frank, how about your team? You guys are all over New York, New Jersey, Long Island. What type of testing options are you guys offering to the patients?
Yeah. Like everybody else, we're having shortages of testing supplies. I mean, we're okay right now, but, there's a shortage of testing swabs. There's a shortage of the viral cultural media. There's shortages of all the materials you need in order to do testing. And the New York State Department of Health has asked outpatient facilities to limit the amount of testing they do so they can save those materials for the hospitals who have to test patients that need to be admitted to the hospital, so you can appropriately cohort those patients. I mean, ideally, one of the great functions of an urgent care could be to rapidly roll out testing for the population so people know who's infected and who's not, so you can appropriately isolate. And that's really what we would love to do. In terms of the Abbott, product, we don't have access to that. They've started rolling it out, but really the rollout has been pretty slow, and there are other point of care testings like the antibody test, which again we would be very interested in. I don't believe the FDA has formally approved any of them. They're going through the phase 3 trials, and they're validating it at this point. And if you could roll out those point of care testings to an outpatient setting, such as ours or RuPaul's and all the other urgent cares and primary care docs across the country, you could really do a public health service by offloading a lot of the burden that's getting to the hospitals right now. But we just, the testing still seems to be, the original sin of this whole epidemic. And if we can overcome that, I think we can really start bending the curve.
Do you think we are testing enough people, under testing, over testing?
No way. Not even close.
Under testing.
We're under testing by orders of magnitude. We're under testing.
Right.
Yeah. There was some study by Stanford, I think, that was on the news last night that did you hear that? That it was like 85%. The actual number of positives is 85% times what we're calling it nationally now.
Yeah. Just to give you a sense, when you do a screening test, you would like your positive rate to be somewhere between 5 and 10%. That means you're testing enough people in order to, be making a dent. So far, we've had over 20,000 positive tests, and that represents 60% of the people that we've tested. So we're getting 60% positives from the people we've tested, which means that we're not testing nearly, we have to test multiple times what we're actually testing.
Wow. And are any of you guys doing, or your team members doing telemedicine during this crisis?
Sure.
Yeah.
Yeah. I mean, obviously, just, in terms of us, even when we diagnose people, we tell them, for your follow-up care, please use, the CityMD app for your follow-up care. So this way we can, monitor you and make sure you're not falling off the curve. Again, like I said, we're seeing tens of thousands of patients, with COVID, and we're managing 95% of them as an outpatient because we know the hospitals are all overrun. The last thing we want to do is bring somebody who's COVID positive back into our clinic to expose the other patients who happen to be there. So what you want to do is you definitely want to use telemedicine. You want to use callbacks. You can even use a telephone just to check on people and see what their breathing status is. Talk to them and how they're doing. They're all going to feel miserable. They all want to know when their fever is going to, subside, when this is going to get better. But just having somebody call up on them, every couple of days, it goes a long way to prevent them from getting worried and then running to the emergency department again. I don't know, RuPaul, I don't know what your experience is with it.
Yeah, so we've set up telemedicine for a lot of our offices, and we're doing video encounters with the patients so we can assess, are they visibly short of breath? Are they gasping for breath? And we're trying to see a lot of our upper respiratory patients through telemedicine to keep from exposing our other patients in the offices. And we've set up drive-through testing in some of our offices so that if patients are assessed over telemedicine and need to be tested, they can just drive through and be tested straight from their car.
That we do with the telemedicine is when they get diagnosed is when we send patients home, likely COVID that we suspect. I know there's a shortage on them now, but those little fingertip O2 sat monitors, that's what we're using to triage before we send to the emergency department. If they have an O2 sat greater than 93%, I know Melissa and her team are not going to admit them in the emergency department. So I tell them, look, go online, buy one of these things that costs like 20 or 30 or 40 bucks, it'll come by Amazon, put it on your finger. And if it drops into the, low 90s or high 80s, that's when you're getting hypoxic and you have to go to seek emergency care. And that's how we're managing a lot of these patients by telemedicine.
Right. No, good point.
Frank, actually about that same topic, do you ask people to walk around their home or apartment with the O2 sat monitor on to see if they get a walking O2 sat?
Yeah, if they have an O2 sat above 93%. If they have an O2 sat of 86% and they're not walking around, I tell them, no, you got to call 911. Don't walk around because it's going to go down.
Yeah.
That's interesting. So, Melissa, in the ER, what I'm hearing from a lot of colleagues is that just about every patient is COVID-19. Are we seeing less of the usual patients, or you also do a lot of orthopedics on the side? So, what do you on the side?
Yeah, that's a good question. We're actually seeing way less of everything else we used to see in the ER, which is it's either because they're all going to urgent care or their primary care doctors or telemedicine, or they're just staying home and dealing with their problems. and a combination of not getting injured as much because people aren't out and about walking around doing their sports, doing their activities. But for example, like vaginal bleeding, first trimester pregnancy bleeding. We're not the orthopedic stuff. I can understand why we're seeing less of it. And that's because people are not out and about. But I don't know where all the GYN complaints went. They don't come to the ER at all. We don't see any STD testing, or rarely see STD testing. We're also not seeing the patients who typically come in with strokes and heart attacks, though there is an uptick in strokes related to COVID. But that's a different topic. The non-COVID strokes and the non-COVID, we're not seeing any real MIs that frequently. One thing we are seeing still are like sickle cell cases in the ER, chronic pain cases like that, and still certainly alcoholics as well, because certainly when liquor stores closed, that became a problem as well.
Right. And Rupal, from the urgent care side, are you seeing less of certain things, or?
Yeah, so for the last few weeks, we continue to see fewer and fewer patients who are not with non-COVID related concerns. Patients seem really reluctant to come in for fear of just being exposed in a healthcare setting. They don't want to be in the office, so they prefer to do some of these complaints through telemedicine. The patients who are coming in with the non-COVID complaints seem to be waiting longer and longer before coming in. And I suspect that we're probably going to see a lot more complications in the near future from untreated UTIs and hypertension that's out of control and diabetes, just because patients are really reluctant to set foot in a healthcare setting.
So with the majority of your patients with COVID-19, Rupal, what are the clinicians treating them? If they're positive with coronavirus, what's the evaluations? How are you treating some of these patients? If as an outpatient, not going to, assuming they're not very sick, what are some of the things you guys are prescribing or not prescribing?
So, we at an outpatient setting, we are not prescribing hydroxychloroquine or Zithromax combination. There's just not as much evidence for it. Patients seem to be requesting it more and more with everything that's going on. We do, recommend that they just continue to monitor their symptoms. Tylenol is needed for their fevers. If they become short of breath, if they're unable to walk across the room or even just complete sentences, we want them to give us a call back. If they start having chest pain, those are all things that, we tell them to look out for. And then, we also advise them to quarantine themselves. If they have other members of the family still living with them, they want to keep as much distance as possible. We teach them how to disinfect their home, things like that.
Frank, do you guys give hydroxychloroquine or Zpack or other supplements?
Well, it's restricted now. So in an outpatient setting, both the governor of New York and the governor of New Jersey have both prohibited outpatient prescriptions of hydroxychloroquine. There was a randomized controlled trial that just got published out of China that showed that the hydroxychloroquine had no effect. And it was the first RCT that actually came out comparing, hydroxychloroquine with standard therapy. So I think people are going to start getting away from that. We did get some initial information about the remdesivir, the early reports that are coming out of the University of Chicago. Again, that's an IV therapy that's not outpatient. What we're doing is, when we're evaluating people, and they have bilateral pneumonia, and you presume it's COVID, but you don't know. Empirically, we're putting them on oral antibiotics for community-acquired pneumonia. So it'll be hydroxychloroquine plus azithro, or it'll be Levaquin, or one of the beta-lactams plus a macrolide or a doxycycline, as the IDSA guidelines dictate for outpatient management of pneumonia, with instructions that, this is likely COVID because we're in the middle of a COVID epidemic. We do test them and we send them home for self-quarantine. I know Rupal mentioned that she was getting test results in 2 to 3 days. That hasn't been our experience. There has been a backlog. So, our wait time has been 7 days. At one point, it was as much as 14 days. So we're starting to get back on the backlog a little bit. But that's how we've been managing our COVID patients. Just to go back to different presentations, my experience has been different than Rupal's in terms of, we're still seeing a lot of the other stuff. We're still seeing a lot of the urinary tract infections. We're still seeing a lot of STD. We're still, and you would think with social distancing you wouldn't. We're still, one of the symptoms of COVID is you get this awful chest pressure. You've had people come in, complaining of like an elephant sitting on your chest. So we are picking up cardiac disease, and there's been, ST elevations of patients coming in. I had one guy who actually asked for the hydroxychloroquine and Zithromax when he was because he thought he was having COVID, and he actually had an anterior wall. We're seeing a lot of the other stuff still coming in. And I think, as it was alluded to before, I think a lot of people are ignoring their chronic disease. Everybody's got COVID on the brain, and I've taken care of diabetics with sugars of 450 and managed that as an outpatient because they don't want to go to the hospital and they can't get a hold of their primary doctor, or they're doing telemedicine and they couldn't get it. They don't have the strips for finger sticks. So there's a lot of stuff coming in that's not COVID to our sites.
Right. Well, thanks, Frank. I guess since you touch upon it, and I'll go back to Rupo and you again, Frank. What do you do when a patient comes to the urgent care and is requesting hydroxychloroquine? I'm sure probably a few people have asked for this. Maybe start with you, Rupo.
Oh, I mean, because there's no real evidence for it, we try to educate patients and let them know that this is not going to be something that's helpful on an outpatient setting. And we just give them that kind of advice and hope that they understand that, as much as they hear about this on the news, that as physicians, we look for the data in it, and there hasn't been anything to suggest that this is going to be helpful for them.
Frank, have you encountered such patients?
Every shift we do, and we just don't give it.
Okay. Very, very straightforward, simple enough. Back to Melissa. So, Melissa, you work in the ER. We're hearing a lot of stories about the presentation of COVID-19. Some have talked about how this reminded them of altitude sickness, and some have felt that putting patients on ventilators too early. They may have to rethink some of that stuff. Just curious about what you're seeing. Do you feel that there's a lot of intubation going on? Is there, you hear on the news there's a lack of ventilators. You're in the front lines. Just love to hear what you're seeing and what do you think of everything.
Yeah. So we're actually not short on ventilators at all. It was thought that we were going to be, and we were all very nervous about that. But I think the highest ventilator utilization we ever used for our hospital system was like 60 or 65% of the ventilators available. And that is because they, of course, got more ventilators and made them more available, and certainly used some of the ventilators that were in the operating rooms. But also we are allowing permissive hypoxia a lot more, and the theory of delayed intubation. And that's because the thought is that intubation actually causes some further lung injury that's long lasting, that makes it very difficult for patients to recover from this. And so in other countries, ventilators had been running short, and that's because they were intubating much earlier, which, at the time, what was thought to be the best thing. But over time, with more and more research, every month we're learning more and more about this disease and trying to make more and more educated decisions. And as more studies come out, and as we learn more and become more comfortable treating it, you change the protocols and you change the way you practice. So one of those is allowing patients to become more hypoxic. In fact, we're trying not to intubate anyone until they tell us they're too tired to breathe. So they could be satting in the 80s, and we, of course, increase their oxygen level every time they could fall below, say, 90, 92%. When they fall below 90, 92%, or they become extremely tachypnic, then we're increasing them from first non-rebreather to then, nasal cannula, then non-rebreather, then BiPAP, and try to minimize the aerosolization of the BiPAP, and then the wall CPAPs and high flow nasal cannula, all of that prior to putting them on a ventilator. And that's been actually shown, I think, to be more beneficial than intubating early. So thank God we have not had to make the decision about who to put on a ventilator and who doesn't get a ventilator, because that was terrifying for all of us. And so I'm kind of happy that protocol changed.
And are you seeing a lot of young adults being admitted or being intubated in the hospital?
Yeah, way more than I ever thought would be. It's hard to know what risk factors make someone who's young more susceptible to getting super sick from this than others, because obviously the research is showing that it's mostly patients over the age of 65 that are really getting very, very sick from this. And when you're younger, it's less so affecting you. And I know obesity has been shown to be a huge risk factor as well as comorbidities. But then what happens in the patients who are in their teens, 20s, and 30s that come in super sick from this? And why are they getting that crazy cytokine storm that that really seems to either kill them or make them super sick to require a ventilator? We don't know, I don't think, unless someone else here has something to add. I would love to know what makes them sicker. And in those patients, they're actually getting steroids earlier. We're using them in a very select patients, because otherwise steroids have been shown to be detrimental for some patients, but very beneficial for others.
And then to Frank and then Rupal. But Frank, so from your end, you're seeing a lot of patients. You've tested thousands. What are some of the insight that you and your colleagues may have when you follow up with these patients? I'm sure you guys follow up with a lot of patients. Do they get better? Do they get sick? Do they come back multiple times? What are you seeing?
You know what? The takeaway that I've gotten so far is this is a tremendously humbling disease. I wish I could give pearls of wisdom here, but the variability of initial presentations and then the variability of where they go from those initial presentations. We've done follow-ups. As Melissa said, I've sent somebody under the age of 20 who wound up in the ICU on event, and no risk factors, no idea why, but they had basically bilateral infiltrates when I saw them, and they were satting terribly. And, the cytokine storm had already started. He went in ARDS, and, he's still in the hospital. He's off the vent now. He survived, but it was a horrendous disease. Likewise, we saw somebody who was in his 80s with bilateral infiltrates, satting at 91%, refused to go to the hospital, said, I'm not going to die in the hospital. If I'm going to die, I'll go home. Send me. I get it. And 2 weeks later, we called him up and he survived. So you have no idea why some people get really, really sick and die from this and they're young. And you don't know why somebody who's older and had every risk factor known to mankind and should have died, they survive. And I wish I could give you a little bit of insight in there, but I can't. It's just, it is a frustratingly variable disease. And there's so much we don't know about this thing yet that I really would hate to put my finger on it and pretend that I know something I don't.
Right. And Rupal, when you guys follow up with your patients, are you noticing any trends or observations?
I'm just going to echo off of what Frank said. I wish I had something to add to that where, there's this one thing that we're seeing with all patients. We're really just not. It's so variable. We're seeing the full spectrum of it. There's some patients that I expect when I call them up and follow up that, they're still going to be sick. And they're saying they're feeling better. And there's some patients that, seemed fine initially and had mild symptoms. And 2 weeks later, they're worse or about the same. We've seen patients who have,
or they're gone.
Yeah. And then we've had patients who have persistent fevers for on and off for 2 to 3 weeks. It's just very variable. I wish there was something that tied this all together, which would make it easier to treat and see, but it's really just so, it's on a full spectrum.
Thanks. So, there's been a lot of talks about PPEs and, whether this virus is airborne or droplet. Certainly we're hearing more healthcare workers are getting sick from this. So maybe start off with you, Rupal. What cautions or precautionary measures have you and your team taken? What are you guys doing to protect yourselves?
Any job in any kind of healthcare setting is a risk. We are trying to be as cautious as possible. So any MA front desk that has contact with patients, we're trying to keep in full PPE, gowns, gloves, masks, goggles. It is exhausting being in PPE for a 12-hour shift. It's hard to breathe through a mask, but it's necessary at this point because we have had staff members get sick and come back positive, even with all the precautions that we're taking. So I feel that, the precautions are necessary, and we need to continue to, advocate for as much PPE as we can.
Are you finding a shortage of PPEs, or is your group able to procure them?
So, I mean, it's a day-to-day thing that we're, staying on top of. We're taking inventory. We're trying as much as possible to have stock available. The N95s, continue to be something that's just very hard to come by for an outpatient setting.
Right.
So we tend to, reuse them.
And Frank, do you feel safe working with all the PPE gear?
Do I feel safe? Yes. So to echo RuPaul, it's a day-to-day thing, and for your viewers who aren't in an epicenter yet, and you're trying to anticipate how much PPE you need. Anybody of our staff that is going to be in contact with patients, yeah, they're going to have a mask, they're going to have a face shield, they're going to have a gown, they're going to have gloves, and you have to use them, and whenever they get contaminated, you got to change them. So if you multiply that by the number of staff and the number of sites and the number of days that you got to treat patients, you could start doing the math and finding out how much PPE. The PPE burn has been really it's tremendous, and I'm sure Melissa, at the hospital, it's even worse. So when you go through your store, yeah, we have enough for the next few days, and yes, but there's a constant, in terms of your operations, you have to have a constant pipeline of this stuff coming in so you can keep all your patients or all your people safe. I don't know, Melissa, you probably opine on the hospital's procurement in terms of it, but you have to take care of your PPE. You have to take care of your people.
Absolutely. To further both RuPaul and Frank's comments, for the hospital, I mean, the amount of PPE that we go through, I mean, environmental needs to wear it, housekeeping needs to wear it, nursing, physicians, residents, anyone who comes, because if you want to properly cohort your patients, especially in the emergency department setting, you have to assume that pretty much everyone has it at this point in a New York City ER. So, and everyone in that space should be using the PPE correctly and wearing PPE. And that's a huge problem, is using the PPE correctly, because if I could have foreseen this coming months ago, we would have, and I'm sure everyone else feels the same way, would have trained every single staff member in the hospital 2 times on how to use and how to don and doff PPE properly. Even many of our physicians don't know how to use it. And now we're utilizing orthopedic surgeons and vascular surgeons and ENT doctors and everyone in the hospital at various ways. And everyone's pitching in to help. But they've never worn PPE before. Many of us, the last time we had to properly train on PPE was for Ebola, but because Ebola was controlled so quickly, I don't know how many people took it seriously. And we certainly did not properly, across the board, I don't think anywhere in the country did we properly train every single staff member, from housekeeping to the techs to the transporters, how to wear, don, and doff PPE properly.
Yeah, I think it's important that you create education that you could push out all your staff at multiple sites, especially, if you're in an urgent care, and you have, RuPaul's got like 100 sites, or, wherever, you got to push out this information. You need to put that in a media that people can readily look at that and learn the right way of donning and doffing PPE, and that's critical. And the only other comment I would make is also the cleaning supplies. Cleaning supplies are in a shortage as well. I just went on I went on Amazon to try and get a gallon of bleach, and I think they were going for like $50 a gallon or something like that right now, because there's a shortage of cleaning supplies. You have to clean all your sites. You have to scrub them all down with the bleach wipes or the peroxide wipes, and you're constantly cleaning surfaces, and you're constantly going through all your cleaning supplies. If you're in an area that hasn't been affected with this yet, you have to think about that. You have to think about how you're going to be cleaning your sites on a regular basis after each one of these sick patients, and you're going to go through your cleaning supplies far faster than you are right now.
So you guys have been wearing PPEs for the last 4 weeks. Have you guys developed any routines before going to work or after work? Any hacks for those who are for those clinicians who are in states maybe not still seeing the peak yet?
So for returning home from work, the fear is just bringing something home, especially if you have other family members in the home. Taking the scrubs off, whether it's in a garage or, the basement, and then showering immediately afterwards is something that a lot of physicians are doing. I also have friends who are physicians in New York City, and if they have a one physician parent, they're living separately from their spouses and their kids just to avoid the exposure.
And to more on what Rupal was saying, I and my colleagues, we bring and wear as little as possible to work. So hopefully, if you work in the hospital, you can get scrubs from a scrub machine. So wear your own clothes to work, change into scrubs, and then get clean scrubs for your next shift. You can do that. But if you don't, then like Rupal said, just wear scrubs, nothing else to the hospital, and strip before you get inside your house if you can, or right at the front door, and wash everything on you. Don't wear any jewelry, a watch, or anything to the hospital or to work. And keep your cell phone in a Ziploc bag, or you can saran wrap it, but it's better to put it in a Ziploc bag. You can bleach your cell phone after with a bleach wipe. Don't dump it in bleach, but a bleach wipe. And you can also text and make phone calls through a Ziploc bag, by the way. We've all gotten very good at doing that. So literally all I bring to work is I bring my driver's license because I'm driving. I bring one credit card just to have, I don't think I probably even need that, a little bit of cash, and I put that in my pocket, no wallet, nothing else. I bring just the key from my car and just one house key. Don't even bring all your other keys, just bare minimum in your pocket. And I bring my cell phone already in a Ziploc. And I bring my face shield that I have bought for myself. I bring an extra N95, just God forbid, in case the hospital runs out, but luckily we're in good supply. I think, is there anything else I'm forgetting? Some people are adding on booties and Tyvek suits. My concern is that if I'm not an expert at doffing and I don't have anyone watching me do it, I'm worried that those are a little bit more dangerous to take off. But a lot of my colleagues are wearing Tyvek suits and all that as well. But we definitely put on gowns before every patient. You basically want to be covered from head to toe is the ideal once you're seeing a COVID patient, and then doff properly. And those recommendations have changed over the last couple of months, and I'm sure it will at your sites too. From what I've heard from colleagues in other cities, initially they don't even, just like for us, they didn't want us wearing masks for any patients that didn't have COVID because they didn't want us to scare the patients. And then eventually we were allowed to wear surgical masks, and then eventually after that we were allowed to wear N95s, and now every patient theoretically has COVID, or we should treat them like they have COVID, and now we're allowed to wear full PPE for everyone. But it's kind of escalated from there, but you kind of have to take care of yourself first and protect yourself.
Thanks, Melissa. So Frank, and this has been a very emotional time for certainly a lot of patients, a lot of families. We all have friends that have lost a loved one, and I'm sure you guys are in the front lines, you're talking to patients, and you're addressing their fears and their concerns. So, what are some common things you think the patients are asking, or some common trends that you're seeing? Are there any things that you've feel that you're repeating yourself multiple times when you're seeing these patients?
Well, sure. One of the things that I'm struck with, the fear that is out there right now. I mean, when you go back and you tell a patient you're COVID positive, I can't tell you how many times I've had somebody just break down in front of me right now and just cry because they're terrified. And I think one of the things that we have to reiterate with patients is most people who get this, they do fine. Okay, you're gonna be miserable. You might have the headache, you might have the cough and the fevers and all that stuff. But most people do fine, and you have to tell them, look, we're going to be here for you. We're going to help you get through this. Okay. Usually, if you're having this conversation, they're not satting at 86%. Those people are in a different category. But I think one of the things that as healthcare professionals that we have to do is we have to maintain empathy in the middle of this and know that while I've given this discussion 1,000 times, this is the first time that particular patient has heard this, and they have to be told look, you're going to be fine with this. We're going to get you through this. This is what to expect. Days 0 through 5, no symptoms. Day 5 through 7, you're going to have a bad cough. You may have some chest pressure. You're going to have a bad headache. Between 7 and 10, you're going to have, really bad headache. You're going to have fever that's going to spike. And then after that, things are going to break, and they're going to get a little bit better, and they're going to get a little bit better, and then they're going to get a little bit better. And this is what you need to do in order to protect yourself and your family. And this is what we're going to be looking out for. And if you need anything, call this number. This is our telehealth number, and we'll get you on the phone with a professional. I think that's one of the things that we're trying to do, because the numbers show that most people do very, very well from this. The fatality rate is probably around 0.5%, and most of those people are going to have comorbid factors, with people that are outliers. And I think it bears repeating over and over and over again. I don't know, Melissa and Rupal, if you can chime in on what your experiences are, but that's been my experience talking to patients.
Yeah, I'm just going to echo on what you said. Upon receiving a positive diagnosis, most patients are just fearful of what that means for them. Does it mean that, I'm going to end up in the hospital? Am I going to be put on a ventilator? And just, as the physician, reassuring the patients that, a lot of these patients who get the diagnosis, they have mild symptoms, and just having them continue to be vigilant and monitor their symptoms. And if they do start to feel worse, reassuring them that their physicians are there for them. If you need the help, seek us out, whether it's coming into the urgent care, whether it's just making an appointment on telemedicine. And then some of the other common questions that we get when patients, have a positive diagnosis is, when can I go back to work? How do I keep from, spreading this to my family? How do I clean my home? And just kind of having those common answers for them is going to be key.
Melissa, I imagine you're seeing much sicker patients. So certainly similar concerns, similar discussions. Any thoughts?
Definitely. Similar concerns. The other question we get is, what mask should I buy or wear if we're discharging them? Can I reuse it or wash it? People love to know. And people love to ask for gloves. They ask us for latex gloves to take home. And then the other thing that I always tell patients when they're diagnosed as positive, or there's a good chance they may come back, or even if they're just worried about COVID in general, is to have a go bag. So have a bag that's packed and ready to go to the hospital, because you will be by yourself, unfortunately. And so you want to make sure you have your chargers and whatever electronics you need, and have whatever information and paperwork you have with you. So everyone has your information, and a contact information list for your most important contacts and things like that. And certainly this is a good time, and I don't want to scare people, but it's also a good time to have conversations about end of life care and who they want called and how they want things to go. So it's good to talk to their family members, their closest friends, and ask them those same questions and have those questions answered for you as well.
Thank you. So,
David, before just to comment about the gloves and for your listeners, other physicians about the gloves, because we get this a lot, and I'm glad Melissa brought it up. If we could have our discussions with our patients about gloves, because gloves are not the end all be all. I hate it when people put on a pair of gloves and then they touch everything. That's not sanitary. You have to have the discussion that, look, I could give you a pair of gloves, but this is how gloves are used. You use once, and then you throw them away. It's important that if you're touching something, the next thing you have to do is Purell or wash your hands. And you have to do that every time you touch something new, because we get this all the time where people come in with these nasty gloves that they've been wearing since they got at the hospital 2 weeks ago, and they've touched everything since then. And it's really important that you go over hand hygiene with your patients as opposed to the gloves. So that is a good opportunity. If somebody's asking you for gloves, I have no problem you wearing a pair of gloves, but they're used, once. And when you touch something, they got to get thrown away.
It's just easier and better for patients just to wash their hands.
Yes.
Most patients do not know how to use gloves properly,
right.
Soap and water,
But I think we have an opportunity as physicians to educate our patients about that, because they always see us with gloves on, but they don't understand how we use them. Rather than giving them gloves, I think it's very important that we teach them, proper hand hygiene, and that is the number one way to prevent this disease from spreading.
And so, we've talked about addressing concerns of the patient. How about the concerns of the staff? You know, a lot of staff members are younger. Have you had to talk to the staff members and address some of their concerns? Maybe start with Rupal.
Yeah, a lot of our staff members have families that they're concerned about, just the exposure with, swabbing the patients and triaging them in the office. The front staff with when patients come in, sometimes they like to get a little too close. We've set markers on the ground. We've just it's an ongoing discussion with the staff on what they need to do to continue to, keep themselves safe and keep their families safe. While they're in the office, we've discussed, having the masks on when you're going to be exposed to the patients in full PPE. And if they start to feel concerned and they have symptoms that are concerning, then we want them to stay home. We don't want them coming in and working sick.
Frank?
Yeah, I think it's important. The staff needs education. They need information. These are really dedicated people, and I think if you walk the walk and you show them the right way to do things and the right way to protect themselves, they feel pretty good. I think for the most part, even when you're dealing with younger staff, everybody's worried about bringing it home to their elderly relatives and elderly siblings, and you have to give them information about how to protect themselves and self-isolate from loved ones who may be older or may have comorbidities. And I think those are the two elements that I think it's imperative that you have these really frank discussions with people about, how to protect themselves and, more importantly, how to protect their loved ones at home. And if you give people really actionable information and you give them the personal protective equipment and the tools and the education in order to protect themselves, I think it goes a long way and there's much less of a problem.
Maybe Melissa, you can share some stories about how the nurses and the MAs in the hospitals are taking care of these patients. They certainly spend a lot of time with patients, and sometimes their stories are not told.
Yeah, I mean, the and medical assistants do amazing work with these patients. They're the ones that are really in the rooms for longer periods of time. We're also calling families well, but they're having to field phone calls at all hours from family members, and that's extremely difficult. Emotional stories of people relaying information from family is just really, really hard. And we actually had some quick visits from family members now. It's just recently started to allow, if a family member is not sick, to allow them to the bedside, which has helped a lot. But the nursing staff has been incredible, as well as all the ancillary staff at treating these patients. Is that what you were asking?
Yeah. I guess, if New York City is 2 weeks ahead of everywhere else, let's say 2 weeks or 4 weeks, and you can rewind the clock and you're advising your former self, or let's say you're advising a colleague in some of the other states and cities, what are some things that you would like to tell them to prepare? What would you have told yourself, let's say 2 to 4 weeks ago? But maybe start off with you, Frank.
Well, I think the governor put it best. We underestimated our enemy on this one early on. I think if we could have secured more PPE and made it a priority to get the private labs on board with point-of-care testings earlier, I think we could have been way ahead of this. And I think we're still playing catch-up at this point. I think those are the two things that I wish we had done this since the beginning of February or late January when this started coming up, and kind of responded the same way that, let's say, South Korea or Taiwan did, and start getting ready, gearing up for this. And I really think we waited until about St. Patrick's Day. I think it was just before St. Patrick's Day that everything was shut down. All the bars and restaurants were closed around that time. If we could have done that 3 or 4 weeks earlier and gotten PPE and testing up and ready by that point, we could have started testing people in February when there was flu season and everybody was coming in because of flu symptoms and those flu negatives. And now I'm wondering, well, were they COVID? If we had the COVID test and I ran it with my flu test, would we have caught more patients and been able to quarantine and then kind of snuff this thing out before it became what it is right now. I mean, if I had a crystal ball and was able to go back in time, that's what I would have wanted to done.
Arupo, how about you? What would you tell other colleagues, other clinicians that have not seen their peak yet? Anything they need to prepare for?
I mean, just to begin stocking up on PPE if you haven't already done so. You will go through a tremendous amount with each patient, with each shift, and then the testing as well. Like, don't be too narrow in who you think has this. This is very varied. It is not just the chest pain. It is not just the fevers and the shortness of breath and the cough. Look for those vague symptoms because you'll be surprised and you'll see a lot more positives if you're on the lookout for it. You know, the vague GI symptoms with the diarrhea and the bloating. We've seen a lot of patients who lose their sense of smell and taste, and that's it. That's the only symptom they present with. Even some skin lesions we're starting to see with some patients. You know, keep an eye out, keep an open mind. This is not something that, you know, falls into a nice little box and, you know, presents itself like, okay, here I am. You know, a lot more patients will have it if you look out for these milder symptoms.
Melissa?
To add to what Rupal and Frank said, definitely, obviously, attain more PPE, but also practice with it, donning and doffing. Now, it is a little too late to start using PPE to practice, but you can grab a couple full sets of PPE and just keep reusing them for the sake of practicing, because obviously you don't want to go through them just for practice. But also, you know, from an ER perspective, figure out how to, or actually even urgent care too, figure out how to socially distance within the facility. You know, we have a lot of issues of passing it on amongst healthcare providers within the hospitals and within offices because we all work in the same lunchroom. You know, people can't wear their PPE into the lunchroom. We get tons of food deliveries into our attending lounge, and we have staff from all over the hospital coming in their PPE to eat, and it's just comical at some points. So we have to figure that part out, and you have to figure it out better if you have time ahead of time. Set up a tent. You can use that tent for donning and doffing. You can use it for outside triage or discharge, but it's a good idea to have a surge plan because when the ER is filled with patients, you need to move some of the staff outside to do some of the work. And it would be really nice to have an area to don and doff appropriately when you enter and leave the facility. Also understand the latest treatments. You know, if we had known, obviously we learn as we go and protocols change as we go, but if we had known some of when we first started in the beginning of March, it would have been more helpful about permissive hypoxia and delayed intubation and about convalescent serum. Now we're ordering 2 type-in screens on every patient who gets admitted in case they need convalescent serum to have antibodies. Also make a website for internal staff to get information and update it regularly. The information, I mean, the number of emails that we must get every day, it's hard to follow it. Of course, we do because we need this information, but set up a weekly staff phone call, whether it's department-wide or hospital-wide, and everyone can get updated information, but also a website that gets updated. And then if you have outside staff coming in to help when there's surge and you have locums people coming in, how will they be oriented? How will they know your hospital system? Set up some kind of an online training module or telephone orientation. And that would be like, I think that kind of summarizes everything.
Also, you're going to need contingency plans in terms of, you know, we have a geographic spread. We're not at one hospital. So we're in like 7 or 8 different counties around the New York City area. And so when the hotspot moves, it's like almost putting out a forest fire, you know, and where the conflagration lights up, you need to reallocate staff from other areas where you're not seeing volume and reallocate them to that place. So one, you have to have those discussions with your teams about how flexible they are. And then you have to have contingency problems about how you're going to get staff to those places because you don't know if public transportation is going to work. You don't know if it's going to be at a regular schedule or if it's a holiday schedule. You don't know how, you know, if you're going to be able to use Uber or stuff like that in terms of getting your staff in and out. And you're going to have staff that are calling out sick or on PTO because they have a sick family member they have to do. So you have to understand, like, logistically, you have to think ahead of time about, you know, think of this as like a bad snowstorm, or think of this as a Hurricane Sandy or something. And this is kind of like a disaster mentality that you're going to have to reallocate resources to where they're most needed. And this is going to change and evolve over the days and weeks of whenever this epidemic hits your site.
And then one last
Really
thing,
good
if you're,
Go ahead.
sorry, one last thing, if your office isn't already equipped for telemedicine, that's something you should really be working on now, because it's going to be an essential tool to continue to see patients who don't want to come in.
Good, very good point. So great advice on, reflecting back. How about the last word on looking forward? What do you think our country looks like in 3 months, 6 months? Are we flattening the curve, and when's it safe to go out? Maybe start off with you, Rupal, about what do you think the future looks like?
So, I think we are making some strides in starting to flatten the curve, but I don't think that this is a sprint. This is definitely going to be a marathon. If we ease up on the regulations of social distancing too soon, we're going to start to see other peaks. So I think to a varying degree, we're going to be physically and socially distancing ourselves for the next 3 to 6 months, perhaps even longer. Whether it's finding new treatments for this or a vaccine, that's really going to be key, and, easing up on some of those regulations.
Frank?
Yeah, I think we're seeing, at least locally in New York, we're seeing a flattening in Manhattan, or at least Manhattan south of 96th Street. I think in Harlem, the Bronx, Central Queens, South Brooklyn, where I do not see a curve flattening. And these are areas where, social determinants of health come into play. The lack of ability for people to socially distance. You have multiple generations living in the same apartments. It's still ripe for this type of a disease to spread. And so we're not seeing flattening of the curves in those areas. So I think the new norm, as it's going, at least in the near future for us in New York City, is, you're still going to have, the pause in place. You are starting to see, and I know the governor just put the edict out that face coverings are going to be required if you're going to be in public. I think that's a good step, because that's going to greatly diminish the transmission of a respiratory illness, if everybody's wearing some kind of a face covering. And I think that might be adopted in other places if and when they start loosening the rules about social distancing. But again, we don't have any effective treatments right now. We don't have a vaccine for this. And honestly, we don't have enough testing. So I think the first thing we're going to need to do is I'm very much looking forward to the antibody testing. Once we scale antibody testing where we can give it and not ration it, and this way we can test, not thousands of people, but millions of people, and find out how much virus is actually out there, how many people are actually infected, identify those people, and then quarantine those people, then we can start flattening the curve. I think I'm optimistic that by the end of summer, we will have 1 or 2 treatments, not cures, but treatments of people who get sick with this disease. And I think that's going to be important to give people a sense of, okay, we actually have some way of fighting this. And again, I don't see a vaccine coming along until for another 12 to 18 months. So around this time next year, I think it might be the earliest that we see a vaccine. And that's when only then do I see us getting back to what we consider normal. So between now and then, I think there's going to be a lot of wearing masks. There's going to be still a lot of social distancing. And I think, some of the things that we took for granted a couple months ago, going to a rock concert, going to a sporting event, going to conferences, I think that's going to be very, very different. I don't see how that's going to be feasible in the short term.
Melissa, do you think, what are your thoughts? Do you think we're going to have a second wave in the fall?
Yeah. As Frank said about the testing, until we can have the antibody test be like an at-home pregnancy test, and be that simple and that easily accessible, none of this will feel under control or somewhat back to normal, because you need to be able to test a lot of people in order to have people properly self-isolate when they have the illness, even if they're asymptomatic. In terms of, how the disease will look in 3 months or in the fall, it's so hard to predict. And I don't think anyone knows if there'll be a seasonal variation or not. But, we're obviously nowhere near the end of this. It seems like the curve is starting to flatten, but it won't really go down until we can test a lot more people.
Just to use the forest fire, we're out there fighting a forest fire, and right now we feel blindfolded because we don't have visibility of where this virus is, and we feel like the hose doesn't have any water because we have no way to treat it. So I mean, that's what we're up against right now. So if we can at least take the blindfold off by the end, by the middle of the summer, I think the three of us would feel a lot better at fighting this disease because we know what we're fighting.
So we're down to our last question. Really not last question, just really the final thoughts. Maybe Rupo, start with you. Just your final thoughts about this whole experience, and any words of advice or insight.
So, I mean, this is something that none of us, really expected to come about. Something that's it's been very difficult to treat. It's been very difficult to see patients with. I see ourselves, continuing in this fight for the next 3, 6, 12 months. We just need to be, vigilant in keeping up with the PPE, protecting ourselves and protecting our patients, educating patients on how to protect themselves and their family members when they do come back positive or are symptomatic. And again, this is going to be a marathon, so we got to take it a day at a time.
Frank, final thoughts?
Yeah, I mean, my thoughts are, I'm really struck with how, amazing group of people that I work with. It's all the people that are showing up every day. Our doors are open, and we see 100, 150 really scared patients every day when we open our doors because they don't feel like they have any place to turn. And I watch our staff, under very, very difficult circumstances, try and give their best in order to, comfort people and give them, adequate medical care under very difficult conditions. When I see the paramedics coming in with yet another patient that they're going to take to the emergency department, these are really, really dedicated people. And I'm struck with how many, really, truly amazing people I work with every day. So, in the middle of an epidemic where there's a lot of bad things going on, it strikes me, how tremendous people are and how they rise to that occasion. So that's my final thought on this epidemic.
Melissa?
My final thought that, all the advice we give you, there's two things that I always tell everyone. One is being home is actually much more stressful than being at work right now. And that's not necessarily because of my kids. It's more because hearing the news and hearing from us and reading emails, it really freaks you out and it makes you terrified and it makes you scared. And then when you go to work, it's scary, but it's actually kind of comforting because you're dealing with all the people that are going through the same thing as you're dealing with rather than your family who's just stressed. And actually it's kind of comforting to be around all the people. It's brought us, all of our staff, much, much closer. I talk to my colleagues more than I ever did before. And it's in that way very comforting. So I would say that even though a lot of what we've said is stressful and maybe making you scared a little bit, I think that in the end, we'll get through this and everyone will work hard together, and being at work is not nearly as stressful as you would think from what everyone is telling you.
Well, thank you, everybody. I just want to thank all three of our guests today. Wonderful insight. Thank you for being in the front lines. You and your team are doing, God's work and taking care of patients, putting yourself at risk. I want to thank you guys again for today, taking some time out of your weekend to share with our audience. This is recorded on YouTube, so for those who can watch us live, they can take a look at this later. And I think that's a wrap for us, and we hope to do this later on. If you're interested in more about Master Clinicians, you can go to our website at masterclinicians.net, and we have a mailing list if you'd like to subscribe. We hope to provide more education and CME for everybody. Thank you, guys.
Thank you. Stay safe.
Thank you.
Thanks.